right, let's answer these questions. Get your blue boxes ready. Routine health maintenance visit, a 42-year-old obese male found to have a fasting glucose of 118. Which one of the following is the most appropriate initial intervention for preventing or delaying the development of diabetes in this patient? So we don't know much else other than he's got at least pre-diabetes. Okay, he's got impaired fasting glucose at a minimum. Doesn't meet the diagnostic criteria for type 2 diabetes. So really the debate here is, should it just be lifestyle? Should it be lifestyle plus metformin or something else? Everybody answered? We got 31 responses. Anybody else? Anybody else? That's probably the best answer, is lifestyle modification. Again, diabetes prevention study has shown this to be more effective than metformin. Okay, not wrong to start metformin here, but if you can get them to exercise, that's costs nothing. There's no adverse effects other than maybe a blister on the foot or something, and so that's the ideal answer there. All right, which of the options below are true regarding the use of TZDs? The full hypoglycemic effect is seen in 2 weeks after the initiation of a given dose. The hypoglycemic effect is comparable to that of metformin or sulfonylurea. Monitoring of liver enzymes is recommended. Weight gain and edema are commonly associated with their use. Their mechanism of action is enhancement of insulin sensitivity. What about A? Is A true? It's more like about 4 weeks, isn't it? So you usually start to see the effects of it at about a month out. B, probably a little bit controversial. The hypoglycemic effect is comparable to that of metformin or sulfonylurea. It's probably a little bit closer to 1%, whereas metformin and sulfonylurea are more like 1 to 2%. And then B, C, and E are all true, right? That makes sense? All right. I think the top of that says that patients diagnosed with type 2 diabetes on the basis of consecutive fasting plasma glucose levels of 138 and 143, which of the following should be prescribed as part of her initial management? So this is a woman that you diagnosed with type 2 diabetes with 2 fasting glucoses of 138 and 143. That's only 20. I know there's at least 35 of you. So this is a little bit different than the last one. The last one, or that was similar to this, it was somebody that had pre-diabetes. This is somebody who has diabetes. And when you diagnose diabetes, you should start them on metformin unless they have a contraindication. So your first step would be lifestyle intervention, diet, exercise, medical nutrition therapy. And then you're going to start them on metformin as well. Some people might say, well, their A1C was 6.6. Should I start them on metformin? And I would say, yes. Okay? They're still meeting glycemic targets. All the bad stuff you hear about trying to lower blood sugars, getting it too low, that's not talking about this patient. That's talking about the patient who's had diabetes for, 15 years, who's got heart disease, that's been on 2 or 3 medicines. This is not a newly diagnosed diabetic who finds out and has an A1C of 6.6, starts diet, exercise, and puts them on metformin, okay? So don't be fearful that I'm going to cause them to have a heart attack because I've lowered their A1C too much. And then also realize that it's going to go up with time. Okay. Hypoglycemia is a possible side effect of which of the following diabetes agents? So a little bit of pharmacology here. Now, I don't know, can you do 2 of these, Sue? Yeah, I don't think this one's going to work real well with that. So which ones are, 1, obviously. 2, no. 3, no. 4, yes. What about 5? We kind of glazed over the glinides, but those are basically sulfonylureas, okay? So yes on 4, and acarbose. Oh, one board question you must know. Patient that's hypoglycemic that takes acarbose, what are you going to give them to raise their blood sugar? And your answer cannot be a rhesus. because that's a disaccharide, that's sucrose, right? So if somebody, you have to give them glucose tablets, okay, because it's a monosaccharide. So make sure you know that. I've seen that a time or two in my life. So that's the one thing about Precoce. Nobody hardly uses it, but just in case. All right. 29-year-old with polycystic ovarian syndrome asks if you can correct her oligomenorrhea and her infertility. Her fasting glucose level is 100 and she has a normal glycosylated hemoglobin. Which of the following diabetes medications have been found to address these problems? So, yeah, you can't, it doesn't work, sorry. Metformin's the answer. Some people might say that Actose might help a little bit with that, but probably metformin is certainly the best answer there. All right. So mark all options that are true regarding the use of metformin. Its efficacy is similar to that of sulfonylureas. It's got a lower secondary failure rate than sulfonylureas. Its hypoglycemic effect is additive to that of sulfonylureas. GI side effects cause 20 to 30% of patients to discontinue its use. That's when I told you that one earlier. About 25% of people have GI symptoms initially, but only 5% have to stop it because of those side effects. So D is not true, and then E is true. You want to stop it if they have a creatinine over 1.5 in men or 1.4 in women. So A is true. B is debatable. C is true. D is false. So I think it's A, C, and E. Oh, we didn't. Well, I think it was A, C, and E on that one. Okay. Which of the following should be used with caution in people with heart failure? All right. So A and B, we talked about B. A, for reasons, we talked about don't use it in class 3 or 4. B, so that one, I think this one is, Sue probably needs to be changed too. Most likely to produce weight loss, metformin.